A lecture over the Penn Villanova basketball game. And of course we know who we're rooting for here, don't we? Well, it is my pleasure to welcome you and to introduce someone who really needs no introduction, but Dean Louise Fitzpatrick will offer you greetings.
Good evening, everyone, and a very warm welcome to this annual event, which has become quite a tradition in the College of Nursing. For those of you that are not aware, it was at our 25th anniversary of the college that we instituted this lecture. And if you look at the back of your program, you'll see that many, many distinguished names of nursing leaders appear there. I might add that tonight is certainly not an exception. Although someone else will be introducing her, we are very proud that Mary Naylor, class of, may I say it, Mary?
It's up there.
Oh, it's up there, okay. 1971 is our distinguished lecturer. She is our distinguished alumna, having received a medallion from the College of Nursing several years ago. She is a distinguished member of our profession. So Mary, we certainly welcome you home to Villanova. For all the rest of you, I want you to know that things are very active and that things in the College of Nursing are going very well. We are enjoying our new home. We've settled in. Those of you that are students know what a difference it is from St. Mary's and how happy and lucky we are to be there. We are getting ready for our 10-year accreditation, which will occur in February. And things really couldn't be better. Villanova is doing a lot. It's planning for its future, and the person that's leading that charge is our president, Father Peter Donahue, and he is with us tonight. He may be going to the game, but that's okay. Someone has to root for Villanova since we're all here. Father Donahue will do that for us in a little bit. I do want to also thank people who organized this event. And to those of you who are alums, and particularly those of you from our clinical agencies who come and join us at this lecture every year, without you, without your cooperation, there is no way that nursing programs at Villanova could survive, let alone thrive. And so for all that you do for Villanova and for the College of Nursing, we are most grateful. I think tonight you will hear about the kind of impact that a nurse and her colleagues can have on changing health care in this country. And so again, I welcome all of you, but particularly my colleague, Mary Naylor. Thank you.
Since 1990, Dr. Mary Naylor has led a multidisciplinary program of research designed to improve quality of care, decrease unnecessary hospitalizations, and reduce healthcare costs for vulnerable, community-based elders. To date, she and her research team have completed 3 National Institute of Nursing funded randomized clinical trials testing and refining the transitional care model, an innovative approach to addressing the needs of high-risk, chronically ill elders and their family caregivers. With the support of several foundations, her research team has recently partnered with a major insurance organization and healthcare plan to translate this model into the real world of clinical practice and promote its widespread adoption. An ongoing clinical trial funded by the Marion S. Ware Alzheimer Program and the National Institute on Aging has expanded testing of this model among hospitalized cognitively impaired elders and their caregivers. Additionally, Dr. Naylor and colleagues are engaged in a funded study by the National Institute on Aging and the National Institute for Nursing Research that will examine over time the natural history of changes in health and quality of life among elders newly admitted to long-term care settings or services. In the 1990s, Dr. Naylor co-led the establishment of a program of all-inclusive care at Penn's School of Nursing. Dr. Naylor also is the National Program Director for the Robert Wood Johnson Foundation-sponsored Interdisciplinary Nursing Quality Research Initiative. The primary goal of this initiative is to generate, disseminate, and translate research that demonstrates nursing's contribution to quality patient care. In recognition of her research and leadership, Dr. Naylor has received numerous awards. In 2004, she was the first nurse selected as a McCann Scholar, the only national award by a private foundation that recognizes outstanding mentors in medicine, nursing, and science. In 2005, Dr. Naylor was elected to the National Academy of Sciences Institute of Medicine. And just this month, at Sigma Theta Tau International Biennial Convention in Indianapolis, she received the Baxter International Foundation's $15,000 Episteme Award for clinical trials and refinement of the transitional care model. But I think most of all, at the moment, Dr. Naylor is most proud of being a brand new grandmother. So, welcome, Mary.
Good evening. Thank you, Dean Fitzpatrick, Dr. DeSaletz, known to me fondly as Louise and Lynn, for this tremendous invitation. It is always exciting to be invited back to the place where you started. Julia Paparella, who is in the audience, reminded me of what a start I had here. She was talking about the first time I gave a lecture in her class, and she said, all through the lecture, she kept trying to tell me to stop chewing the gum. So, well, Julia, I put the gum under the table tonight, and so I'm delighted. It is really an honor to be here, and Louise knows this, and anyone who's ever heard me speak to an audience like this, that I am extraordinarily proud of my Villanova roots. I really believe that in this environment and in this context, that I really had the opportunity to begin to develop the sets of knowledge and skills and especially values that have influenced me tremendously throughout my life. A real appreciation of liberal arts and sciences and the contributions they have to helping us understand issues, the big issues in this country, and most especially a love and appreciation for a discipline that is not always as visible as it needs to be in the public's eye, but that I think has more to give and bring to the human experience than any other discipline that I know of, at least. Of course, I have a bit of a bias. So one of the things I learned at Villanova is that you should only focus on big problems, and that is where you have the greatest capacity to make a huge difference. And so our team decided to focus on this notion that we are all here on, unless hit by a bus, on a path from here to infirmity. And while this is I'm way down there where that arrow is, but many of us are traveling on this road as a result of great advances in science and technology that are enabling people to live much longer lives, but they are living those longer lives often confronting increasing numbers of chronic illnesses. Chronic illnesses in this country is the #1 public health problem. It consumes 75 cents of every healthcare dollar that we spend. And given the growth and expected growth in the aging of the population, we are really on the precipice of a major crisis unless we begin to appreciate how it is that we can delay chronic illness and how it is that we can better address the needs of chronically ill people and their family caregivers. And so tonight I want to share with you a little part of a journey that I've been on with a terrific group of colleagues from the schools of nursing, medicine, from the Wharton School, Annenberg, arts and sciences, to try to really understand how we can make a difference. But I must say to you that the work that we've been doing is really placing a spotlight on nursing and nursing's capacity to take the lead in addressing this major crisis. So let me start by telling you a story about someone that lives not very far from here. In fact, he is, and he's allowed us to tell us his story in case all of you are concerned about his HIPAA protection. But Mr. Jenkins lives here on the main line, and at the time that we began to know him in our work, he described himself as a 76-year young individual. He was a retired investment broker. He was a graduate of a very famous college, and very famous business school, very, very close by. He lived here and had been living with his wife for over 50 years and his wonderful marriage, 3 children who were very connected emotionally, but not geographically. They lived in many states, but very engaged in the lives of their parents, etc. Mr. Jenkins had enjoyed a very full life, both in terms of his work, as well as his philanthropy, as well as his love of golf, etc. But like many people, along the way, he experienced some health issues, had the heart attack that resulted in him being able to survive, but now dealing with heart failure. He had diabetes, hypertension, and the whole list of chronic illnesses that are very, very common in individuals as they age in place. He also was beginning to notice some changes in his wife, his beloved wife of 50 years, sensing that she wasn't quite the same, sensing that she had some changes in terms of cognition. This was an enormous source of concern to him, enormous, more than even his own health problems. This was threatening his sense of well-being, seeing these changes in his wife. He had been in and out of the hospital 6 times in the 6 months prior to beginning, before we began to work with him. And so really there was and he, in so many ways, is prototypical of what is happening to many chronically ill older adults in this country. This churning in and out of the emergency room and hospital, dealing with and successfully dealing with acute phases of chronic illnesses, but never, ever stopping that trajectory. So I want to tell you a little bit about why he is like so many people in this country, and in so many ways, he is not. He is like many people in that he suffers every day, wakes up every day, dealing with multiple chronic conditions. He was on 14 prescribed meds at the time we met him, taking many of them multiple times a day. He had some functional deficits as a result of his illnesses. He had emotional issues, mainly associated with anxiety about his wife. He did not have issues around poor general health behaviors, but that is a common concern among many other people suffering from this trajectory. He did have a poor subjective health rating. If you asked him how he would rate his overall health, even though many other people would say he's doing fine, he rated it as poor. He did not have a lack of support. He was well supported in his family, but many other people in this same situation have absent or unwilling social support systems. He did not have cognitive impairment, but many people in this same situation have their entire care picture complicated by loss of executive function, cognition, etc. And unlike many others, language and literacy and culture were not challenges for him, but once again, for about 40% of the older adults in this country, health illiteracy is a problem. Many of them experience, and as we grow in diversity, problems associated with language and culture. So he had many of those factors, but many others he was in really great shape with. But what he confronted were the same sets of issues that everyone else did. We do not have a system well equipped to address his needs. Mr. Jenkins had had a primary care physician of 30 years who went to live in Florida. So his care was then left to seven different physicians, each taking care of one part of his body, but nobody taking care of his whole. He suffered from inconsistent medical management, as he would go to one provider, They would recommend X treatment, another would Y, and often they conflicted with each other. Poor communication was a constant for him and for all of the others that I'm going to describe. He did not experience limited access to services just because he had financial resources, but many people in this country, even though they're on Medicare, do not have access to the kinds of care and supports and services that they need. He confronted, as many people in this situation do, this sense of narrow perceived accountability. When he was hospitalized on a Friday night, he would have a very excellent team of nurses, physicians, and others work with him to address his acute care problem. So by Monday morning, he was relieved of that acute illness. He could breathe easier, etc. But then they sensed that they were done with him. He's now ready to be discharged, and they're focusing once again on someone coming in an acute care crisis. So this perceived accountability by many people in our country is what happens to people door to door when they come into the hospital until they're discharged, and then their accountability is no more. And we don't have in this country systems that help people bridge these transitions. I was working with the Senate Committee on Aging in the mid-1980s when we implemented this DRG system, this prospective payment system that significantly shortened lengths of hospital stay. But what we never did when that fundamental change in financing of healthcare came into place was to say, what is needed to help people now who are going home in 2 or 3 or 4 days, who are still acutely ill, who still need support? And we did nothing. And the result was a massive increase of number of people going through Mr. Jenkins' experience, multiple hospitalizations in a short period of time. So the case for transitional care is a very compelling one in this country. We have very high rates of medical errors. One of our postdoc, Dr. Jan Faust, some of you in this audience know her, took a look at just the rates of medication errors between hospital and home in one of the studies that we conducted, and found that 7 out of 10 people had an error with medications just in the transition from hospital to home. Sometimes they would get home and not have the right dosage. Sometimes they wouldn't know whether or not the medications they were taking before they were hospitalized, should they continue those? There were huge amounts of errors, and many of these errors affected medications that are very important to people, such as anticoagulants, ACE inhibitors, etc. Consistently across every study, people are rating the quality of the experience as they move from hospital to home, their satisfaction with care, as very poor, both the patients and family caregivers. Very high rates of preventable readmissions. In this country, about 1/4 to 1/3 of all readmissions of Medicare beneficiaries are estimated to be preventable, meaning if we did a better job of caring for these people while they were in the community, we could be in a much better position to prevent them from having this very difficult experience. And I want to highlight that this is a tremendously human burden, to have people having to go through this in and out of the hospital, both for themselves and especially for their loved ones. To watch that experience is tremendously trying. So it is a burden at a human level and at a societal level. So what we began to think about 20 years ago, and actually we built on work that had been done by Dottie Bruton and her colleagues at Penn, who had been working with this notion of transitional care to think about ways to help very low birth weight infants, people at the other end of the life spectrum, be able to be discharged earlier with the right level of support and services. We began to think about how could we apply this with an equally vulnerable population at the other end of the life spectrum. And so we began this work on transitional care. We actually our teams have helped to define what this means. The American Geriatric Society talks about it as services or environments that help at-risk populations navigate this very challenging environment, hospital to home, in order to assure better continuity, in order to prevent the common breakdowns and gaps in care that cause unnecessary but very troublesome burdens to individuals and to our society. And I wanted to share a little bit about the context of transitional care, because most people think about acute care as happening in the hospital. But acute care services today are being delivered as a result of shortened lengths of hospital stay over time. So we're picking people up who come into an emergency room, often go to intensive care unit, and back to a floor. Just in period of a couple hours, they have multiple transitions, multiple handoffs between providers from one unit to another. They are then discharged, and increasingly older adults are being discharged to rehab settings or post-acute environments in skilled facilities and spending a couple of days to a couple of weeks there. And then their handoff is back to their primary care providers or those 7 specialist physicians responsible for their care. Now, many of the adults that are going through this are going to do fine. They have great support systems, they don't have all of these chronic conditions, etc., and they, with the right level of support that you give them through your discharge planning, etc., will do well. But this population that we focus on, individuals with multiple chronic conditions and individuals who are at end of life and who are coming in and out of the hospital and who certainly don't need to be there, who don't want to be there, this is a growing population for our focus. So the work that we've been doing it's the quality cost model of transitional care, and it starts with this notion that we know now who coming into our emergency room and our hospital are at high risk for poor outcomes. We've developed in our work and in others a risk profile that enables us to be able to target an intervention to those who are going to benefit the most from it. The model started 20 years ago with words that are now very common in the language. It's all about engaging people, engaging individuals, engaging their family caregivers. We start every intervention trying to identify what is important to this individual, what are their goals. Mr. Jenkins' goal, believe it or not, was to get back on a golf course and to be able to do at least 9 holes. In addition, his goal was to get care for his wife. We then start with this notion, we do not accept that people are well managed. In fact, we've learned that many of the people that we're caring for today are not well managed. Cynthia Boyd and her colleagues at Hopkins showed that even if you applied the best evidence for the care of individuals with diabetes, heart failure, hypertension, etc., the best evidence, that you end up with a care plan in which people are on way too many medications and they negatively interact with each other. We haven't figured out, and we don't have the science yet that helps us understand how to best care for people who have multiple chronic conditions. So we work very much on the issue of managing symptoms, streamlining plans of care, getting people as much as we can from 14 meds down to 10 meds or 9 meds, because honestly, you all know this, the simpler the treatment plan, the more likely people are going to adhere to it. Most times people are on too many drugs, too many therapies, they don't feel good as a result of it, and they don't adhere to it. We spent then a lot of time trying to position people to understand how to better manage themselves, because ultimately we place a tremendous amount of responsibility on patients and on family caregivers without providing them with the tools that they need, the knowledge that they need, the skills that they need to do it well. So we spend a lot of time on that effort. And all of our model is based on principles that you all learned in Nursing 101. Collaboration with other team members is central. Continuity of care is vital. Coordinating of care, integrating multiple cares, and ultimately the relationship that you have with your patients and with your family caregivers is what will make it work. The trust that you can establish with individuals will enable them to be able to have conversations with you that they often can't have with their providers in the 20 minutes or 15-minute visits that they have. So this is the vital contribution that you can make that no other profession is as well equipped to do as you are. So the unique features, and I long for the day when I don't have to say the unique features of this model are that the care in this work, as we've tested it, is delivered by advanced practice nurses, master's prepared nurses who have advanced knowledge and skill in the care of this population, who really know what it means to really make a difference in the lives of people, chronically ill people, as they move across this crazy system. These nurses are delivering the services. They're picking people up at hospital admission. They're following them. They're working with patients while they're hospitalized to prevent all of the medical errors that we know are the seeds of readmission. They start in a hospital, the infections and all of those other things that can go wrong that may not manifest themselves in terms of poor outcomes till later. They follow the patients into the skilled nursing facilities, and then they follow them into their homes, substituting for traditional visiting nurse services, because this is about the relationship between that nurse and that patient and family caregiver over a very vulnerable time. They imply an evidence-based protocol that we've developed over time, and their focus is not on doing a better job in promoting just the handoff, but rather, how can I use this opportunity with this patient and family caregiver to interrupt the chronic illness trajectory that they're on, to really stop this in and out of the hospital, to improve their quality of life and the dignity. I know that those are the themes that are very much resonate with this group, these individuals' sense of self-worth. Well, let me briefly take you through the journey in terms of the science so you can get a sense of what we were attempting to do. And someone says, well, how did you know you were going to end up there? I said, we never did. We started with a question, and the question really came and bubbled up from our experience, my experience with the Senate Committee on Aging, asking the question, look at, if people are being discharged earlier, 2 or 3 or 4 days on average earlier than they were before, is there something we could do better in terms of preparing them for that discharge and for what they will experience when they get home? So our first study was to really look at whether or not a discharge planning protocol that was designed specifically for these older adults and their family caregivers that included some telephone follow-up could have an impact. And what we learned is that it could. It did. In fact, we were able to demonstrate reductions in readmissions for the short term and healthcare savings for the short term. What we began to appreciate, though, was that there was a group of individuals in our study who didn't do as well as others, and that became the focal point of our second study. And this was, then the question was raised, well, what if we targeted those individuals that we learned from our initial work didn't do as well, this high-risk group? And what if we added a home care component and targeted individuals who are being hospitalized for a whole range of medical and surgical problems? Could we make a difference in the care and outcomes of these individuals and their family caregivers? And this paper was published in JAMA, and it demonstrated that for many, in fact, most of the medical or surgical conditions that became the focal point of our work, and really our work wasn't focused on the conditions per se, but the reason for hospitalization. Then we were able to demonstrate reductions in readmissions through 6 months post-discharge at mean savings for each Medicare beneficiary of $3,000 per member. But one group that didn't do well in this intervention were older adults with heart failure. And they became a very important focal point of our work. Older adults with heart failure are emblematic of the challenges of Mr. Jenkins. They're individuals for whom, living with end-stage diseases, who are often coping with multiple other kinds of problems. Depression is a very common coexisting condition in older adults with heart failure. We learned not so much from the clinical trial, the work of testing and intervention and measuring its impact, but all along the way we've been keeping detailed case studies on each of the individuals that we enroll and each of the families that we enroll in our study. And it's through those case studies that we can begin to appreciate what didn't work. Why didn't it work? Why did it work for older adults who had one type of problem, but not for older adults with heart failure? And that enabled us to go back to our major funder up to this point in time, the National Institute of Nursing Research, and say, look, we really want to target individuals who are dealing with the greatest complexity. Lots of physical health problems, it's often challenged by health literacy, depression, etc. And we now think, as a result of these case studies, we have a better sense of what we need to do for them. And we were very successful. This is a very important study in that we were able to demonstrate the thing that we set out to do. Demonstrate long-term reductions. In this case, for the intervention group, we significantly reduced readmissions through 1 year post-discharge at substantial savings for each Medicare beneficiary, even after accounting for the total cost of the intervention. So you don't need to read this, but I wanted to give you a sense of what it is that we're doing. And this, by the way, is not a model we started out with. This is a model that has evolved from the science that we've been able to produce over time. So we pick people up at hospital admission. We screen and we say, Mr. Jenkins, you need our study. You need to be receiving this kind of service. The transitional care nurse, the advanced practice nurse, begins immediately the interaction and relationship with Mr. Jenkins and his family, the 3 children in different states. The transitional care nurse reaches out not just to the physician who brought this patient in or for whom this problem, the cardiologist if the patient is coming in for a heart condition, but to all of the physicians involved in their care, including the primary care physician who often doesn't know that Mr. Jenkins has been hospitalized, because they all have information about this patient that is never in a chart. It is never communicated, but all of it's critical information that will help us streamline. The nurse begins to work with the staff on the unit to help them figure out how to prevent the bad things that often happen to older adults in hospitals today, the preventable infections, the prevention of delirium, etc. We'll begin to work with the pharmacist in a plan of care and say, this is the medication regimen that Mr. Jenkins is on. What can we do to streamline it? And then begin to work with the physicians to get them on board with the new medication. They'll reach out to the physical therapist because many of these people are really at a low ebb functionally, physically, and begin to say, what can we do to begin to restore Mr. Jenkins back to the point where he can do the things that give him a sense of meaning and value in his life, etc. So they do all this while the patient is hospitalized. They're in the patient's home. If the patient goes to the skilled nursing facility, they follow them there. If they go home, they're in the home within 24 hours, because we have learned that you cannot believe how many things can go wrong with patients during the first 24 hours. Often they're not accessing the services that they need to make sure they continue. They're not often getting the medications into their home in the time that they need them. They begin to make mistakes. We think we've done a great job, and you have done a great job teaching while patients are hospitalized, but guess what? They're too stressed. Their families are too stressed. They cannot at all appreciate all that you've done. So we've learned that a lot of the work around patient teaching and education cannot take place successfully in the patient's home. What we have learned is that you can do a lot in the patient's home, though, to make up for that. The nurse goes with the patient to the very first visit to the primary care physician so that there is really excellent communication about what happened in the hospital, the new plan of care, so that this primary care physician, who often has not received the discharge notes and doesn't know that the patient has even been hospitalized, is on top of it. The other thing that this contact does, it enables that physician to establish a relationship with the nurse, so that 2 weeks hence, when the nurse is in the patient's home and Mrs. Smith's running into trouble, he can call, and someone at the other end knows that this is a master's prepared nurse. They can collaborate about and problem solve, and the knee-jerk response of sending them into the emergency room doesn't occur. And that's part of it. This relationship is not just with other physicians. And they continue to work with these patients. About 20% of the patients that we're enrolling in our current work are individuals at end of life who really need to be, as I said, if they choose to be receiving palliative care. Certainly, all of them need to be receiving excellent palliative care, but many of them need to have the trusting relationship to be able to talk through decisions about end-of-life care. And then the nurse, if the patients and family caregivers get on board, has a great challenge of convincing the 7 specialists that that's a good plan of care for this patient. So there's a lot of important work that goes on here to transition them. There is a handoff from the transitional care model back to, it's an average intervention of 2, maybe 3 months. The handoff is back to the primary care physician or clinicians or nurse practitioners. And what this handoff enables everyone to do is to know exactly where this patient started, what goals were established, what progress was made, and what these providers who are continuing to be involved in the care of this patient need to do in order to assure continued positive outcomes. And so that's essentially what happens. So I've told you a little bit about applying the model to Mr. Jenkins and his family, because this is an intervention that's targeting not just the patient, but all of the people and family caregivers broadly defined that really are going to have an impact on the care and experience of this individual. And so for Mr. Jenkins, as you'll recall, he was tremendously concerned about his wife, but had never been able to express it. And the relationship with this nurse enabled him to be able to voice that concern, and enabled that nurse to be able to get Mrs. Jenkins assessed in a geriatric center for cognitive impairment and begin to get the kind of care and support that she needed in order to continue on her journey, etc. This is part of the work that we do. So the core components of this model are that it is holistic. This is not, many times people have poor outcomes or don't do well, and it has nothing to do with their medical care. It has a lot to do with the fact that they don't have adequate social support, that they don't have enough understanding or knowledge or skills about how to early identify that they're running into problems. Sometimes it's because that they don't have someone when they call and are in trouble who is as responsive as they need to be. Sometimes we've been successful in getting people to change primary care clinicians because they never had one who was really being responsive to their needs. So it's all about figuring out what are the 2 or 3 or 4 big issues that if I don't address during the course of the time that I have, this very precious time I have with these individuals, that they are likely not to do well, that they are likely to continue to get back on that cycle of churning in and out of the emergency room. It is a nurse-led but clearly multidisciplinary team model. We would never be able to accomplish what we're doing without the real active collaboration with physicians, social workers, pharmacists, you name it. It is protocol guided, and it places a premium on simplification. As simple as we can get a plan of care, the better off we are for everyone involved, most especially patients and family caregiver. It relies on a single point person throughout a very vulnerable time, the nurse, from hospital admission through an average of 2 to 3 months post-discharge, who is available 7 days a week by phone, who will be there to get into that patient's home as needed. That is the person, single point person, the broker of care throughout that time. And we've incorporated in recent years information and communication systems that span all these settings. So what have we shown? Well, across the clinical trials, and these are large-scale clinical trials, multi-site, completed to date, we have shown consistently that the transitional care model has increased the time from hospital discharge to first readmission. It has improved physical function, and in our most recent trial, which is the first one we measured it, improved quality of life. And for many individuals, this is the core goal. For them, it's about having a high quality of life. It has increased patient satisfaction, decreased total all-cause readmissions, and decreased total healthcare cost. So this gives you a sense, because this is what drew national attention to the model, not so much that it improved the quality of life of individuals, but it had a major impact on hospital readmissions. So I want to tell you, in the first study that I talked about, we were able to reduce hospital readmissions compared to the control group by over 50%. In the second study, where we measured through 6 months, we also had a 50% reduction compared to the control group. And at 52 weeks, this is a significant reduction of 13% at 52 weeks. And this also drew a great deal of attention, that we were able to demonstrate mean savings, all healthcare costs. These are the costs not just of hospitals, but home health services, physician costs, emergency room costs, et cetera. The only things we didn't measure were medication costs. So after taking into account the cost of the intervention, we've demonstrated, for example, in the most recent clinical trial, an average of $5,000 per Medicare beneficiary savings with the use of this model. So now you would think, wow, publish that, people will just pick it up and begin to embrace it immediately. And honestly, we did. I mean, it was published in all the right places. It received a great deal of attention, et cetera. But the realities are we confronted a wall. And the wall were the barriers to care that exist in an environment right now that continues to focus on acute care services. The first is that we have an organization or system of care that places everything in silos. So we have hospital care, and you hand off to skilled nursing facility, and you hand off to home health services, et cetera, all with their own eligibility. And heaven forbid you're in a long-term care setting, because then you have 2 different payment streams and a whole numbers of perverse incentives that make one side want to push another into the hospital. There are substantial regulatory barriers. We do not have quality and financial incentives. We measure quality of care in each of those silos. We do not measure care that is aligned with the patient's experience as they move, from hospital to skilled nursing facility. I mean, what people want, what patients want, we don't measure. We measure errors in hospitals and errors in home health facilities, et cetera, but we don't measure how a person felt about this experience and whether or not over the course of an entire episode of an acute illness, they were cared for well. We do not reimburse. CMS, the Medicare program, Centers for Medicare and Medicaid Services, does not reimburse this approach to care. But fundamentally, what it does, it flies in the face of the culture of care in this country, which is still very much placing a premium on what happens in hospitals. And believe me, hospitals are central. They're essential. And I'm not at all saying that we shouldn't be paying attention to what happens to patients in hospitals. But we could do a much better job in promoting quality and assuring quality of life for many, many people in this country if we spent more time focusing on how to keep them out of the hospital. Also, we've not placed a premium on longitudinal care, having the kind of relationships with people over time that allows great things to happen. And finally, we have not really placed a premium on team-based care, where nurses work as partners with physicians and social workers, because honestly, to get this work done, it requires a great team. So we started then, I will not use the expression I often use with an older audience, with this Irma Bombeck. Does anybody here know who Irma Bombeck is? Okay, good. 3 people, okay. Anyway, this comedic phase in our lives where we tried to figure out how to take evidence and make it happen in the real world of clinical practice. In fact, Penn, Office of Technology Transfer, decided to start a business on the transitional care model. We recruited a CEO who went out to get some venture capital to run the business, and he was recruited by a venture capitalist to run another business. So before we even opened the door, the business failed. But we had so many business plans. My entire office was filled with a set of business plans. So finally what I decided to do was to have myself seated at a dinner next to Jack Rowe, who was then president of Aetna. And the reason that I thought he would be a good person to sit next to was he's president of Aetna, but he was a geriatrician. I thought, well, maybe he'd get it. And by the time dinner was over, we had plans for his medical director to come and talk with our team to see whether or not we could form a partnership. And indeed, with the support of 100 different foundations, because NIH does not fund this kind of work, we had to go out and seek support from a number. Commonwealth was the first to come to the plate, and ultimately 4 other foundations joined. We began a partnership to say, can you take evidence-generated randomized clinical trials and put it into real work, the workflow processes in an organization to affect the care and outcomes of people? We built a wonderful national advisory committee, and the head of aging from Kaiser Permanente was on that, and he said, I think we could really benefit from this. So we expanded the partnership to work with both Aetna and Kaiser Permanente. And as I mentioned, some of the lessons along the way, and this was a program director at Commonwealth who said, get on your advisory committee for this project, everyone, a representative from every major group that you think you need to influence in order to make this model accessible worldwide. And so we brought people on from the policy world, CMS, Pacific Care, from the other insurers, Quality World, the Veterans Affairs, National Quality Forum, which is a group that endorses measures, lack of quality measures, et cetera. And that was priceless. Interestingly, we didn't have any tools of translation. We had clinical trials and lots of data, but we didn't have anything that we could hand off to you to say, you want to do transitional care tomorrow? Here are sets of tools. So we had to build a number of them, all evidence-based. Patient screening and recruitment. We developed a set of web-based training modules to orient the nurses. We had to build a clinical information system that houses our risk profile, our intervention protocol, our documentation system, and that links to how you monitor clinical and quality and economic outcomes. We had to build a system that will allow for continuous quality improvement so that the nurses, because we don't prepare nurses to deliver these services. Now, Villanova may be doing that, but most schools do not prepare nurses to deliver these kinds of services, et cetera. So it's not intuitive that nurses who are working in hospitals can deliver care in skilled nursing facilities and homes. This is not something that if you spent 20 years in an intensive care unit, that you are confident to be able to do it. So we had to prepare nurses to deliver services across all these settings in a collaborative model, et cetera. And we used case conferences as the primary vehicle to do that, and root cause analysis. So nurses come to conferences, we do them via conference call, et cetera. Clinical leaders at Penn, who are part of our team, guide these nurses through. They present their cases, they talk about what works, what didn't work, and we use root cause analysis to say, why didn't it work? Or if it did work, what did you do that made it work? And this becomes a vehicle to enable the nurses to become really skilled. And we're starting off with expert nurses, but this is really getting them skilled in this very, very complex work. And then we needed to give tools for translation. So the good news is, with the Aetna work, which we completed, and by the way, let me just tell you what we didn't know. When we started with Aetna, I thought Aetna that would have nurses that could deliver this service, and it turns out that Aetna's legal barriers, their insurance barriers, their state laws that prevent the nurses from delivering other than case management or case conferences, et cetera. So we had to find another partner to actually house this program and so on. So we went to home care. We had to build a new service line within the home care agency. We have one of the nurses delivering that service in the audience tonight. We had to develop new position descriptions. We had to figure out what we were going to pay those nurses, et cetera. Anyway, we implemented the model in a testing, in a demonstration with a couple of hundred members, Aetna members in the Mid-Atlantic region. And fortunately, we were able to replicate that we could achieve high quality and patient satisfaction. In this case, we looked at patient satisfaction and physician satisfaction, that we were able to reduce hospital readmissions and associated costs. So Aetna defined it as a high value proposition. And some of these, all along the way, we had an organizational consultant work with us to say, what's it take to do this? What does it take to take evidence and move it, both in the startup phase and rollout phase, in real life organizations? And here are just some of the key lessons. Strong champions. We had leadership at Aetna that was unbelievable. Dr. Randy Krakauer, who was the medical director, this project could have fallen through the cracks it was so complex, so challenging. He believed in it, he was committed to it, and he kept everybody on target. The fit of the innovation is critical. Aetna was very interested in improving the quality as well as decreasing resource use, so this was a fit. The business case that we had to make to them was very important. And so all of these other lessons, you needed excellent communication. In the beginning, we did not do a very good job of involving the frontline case managers at Aetna, and that came back to bite us. So we then had to figure out how to really make sure that we were having excellent communication with all of the people that were going to have some responsibility for helping to implement this model. So let me just briefly tell you where we are to date. As a result of our work with Aetna, they have proposed expansion of the transitional care model to other markets as part of their strategic plan in 2009. The Kaiser work is ongoing. The University of Pennsylvania Health System has adopted the transitional care model. If you live long enough, you can be a prophet in your own land. We all know what happens to profits when it doesn't work, et cetera. We then have had local insurers. Blue Cross is currently reimbursing, paying for those services for its members, and Aetna will be coming on board quickly, again, only at the University of Pennsylvania Health System. And we're working with a couple of quality improvement organizations. These are organizations that are out of the Medicare program that are explicitly designed to improve the care of Medicare beneficiaries throughout the country. 14 states have been asked to focus on care transitions, and 2 of them, New York and New Jersey, have begun to work with us in terms of implementing the transitional care model. So what are our ongoing efforts? So, we're most interested in continuing, obviously, to advance the science, to really help us understand how on that path to infirmity that I talked about, we can really keep people as far away from progressing on that path as we can. We are vitally interested in changing the way in which chronic illness care is delivered in this country. We are also interested, and we think one vehicle to do that is promoting widespread adoption, and we're using our findings to promote policy changes. So let me just briefly tell you about two ongoing studies that are helping us to think about ways we can expand the model. Up to this point in time, our work has been with cognitively intact complex elders transitioning from hospital to home. Our current study is looking at older adults who are hospitalized who are cognitively impaired. When we published the study in JAMA, we received a call from the Alzheimer's Association, and Katie Maslow, then and still one of the major policy leaders there, said, "You have taken on a very easy population. Individuals, yeah, they're complex, and yeah, they have all those problems, but they're still cognitively intact." So they gave us our first grant, and it was a sizable one, without having to write a proposal. If we committed ourselves to make the case to the National Institutes of Health for a large-scale study of the transitional care model with their population, cognitively impaired. We sent nurses who were trained and prepared to do cognitive assessments to 6 or 7 hospitals in our area, and it was just a very small sample, a couple hundred people, but they assessed people who were coming in for a fractured hip or an acute episode of heart failure or diabetes, and they found that 35% of those individuals had cognitive impairment as a coexisting problem. 65% of that number, nobody had identified. Or they won't. They might, nurses sometimes use the word a little confused, etc. But these are individuals that were not identified by themselves, by their caregivers, by anybody as having cognitive impairment. Now, they're the same individuals that we're sending home on a Friday afternoon with an average of 3 new prescriptions to try, and many of them don't have impaired executive function. They could no way figure this out, etc., and nobody even knew it. So it wasn't a difficult case to make. So this particular work is testing the transitional care model with this population, and we're about 4 years into a 5-year study. And then finally, there has been a huge problem in this country, growing problem, as people are entering long-term care, who are having now to navigate a long-term care system, an acute care system. We are seeing very high increases in rates of hospitalizations among, for example, older adults in nursing homes, going in and out. These are the most vulnerable individuals who require support with activities of daily living like feeding, etc., going into an acute care environment where the nurses and others are so stressed just trying to meet the needs of the acute illness, let alone spending an hour trying to adapt a feeding program to this older adult, etc., in order to make sure they're adequately nourished. So we are really thinking that this is a great opportunity for us to impact the lives and outcomes of a very frail population. But unfortunately, we really didn't understand at the time we were thinking about this, what was the natural experience? What's the real history of older adults once they enter long-term care? So we have a study ongoing in which we are enrolling about 500 older adults, English and Spanish speaking, and we're literally following them, interviewing them every 3 months, collecting data from multiple sources to understand the natural history of changes in health and quality of life for that population. And then we're exploring very specifically what happens when there's an acute care transition and how does that change that trajectory for those individuals. We think that this will position us to be able then to expand testing of the model. Let me tell you very briefly then about some of the strategies that we're using to promote its adoption. We are working with a number of national and international collaborations and consultations. We've created a website. We've done a bit with media, and recently the program was featured in the Wall Street Journal, Washington Post, and PBS, and so on. And it's been recognized as an innovative model of care in many of the groups that are trying to make accessible to public, to providers to organizations, where are there evidence-based approaches to address this population. In terms of health policy, we've been writing policy briefs, providing congressional testimony on the Hill. We've been working, spent 2 days down with the Medicare Payment Commission, which is the group that figures out how we pay and what we pay and who we pay, in order to convince them that they should begin to think about paying for transitional care services.
The idea that you have been able to do a natural history study, which is very unusual in this day and age, because once there's a treatment known for something, it almost becomes problematic to do a natural history study without intervening, and yet what you're talking about in a natural history study with people with Alzheimer's is perfect, and it sounds like a terrific idea. Thank you. So that was just a comment.
Thank you.
The second is really a question, Mary, and that is, with all that is happening in Washington right now in terms of healthcare reform, how does what's happening affect the model, and how does the model in turn affect what's happening in terms of healthcare reform, which I think you talked about a little bit,
right.
but the initial, which is how does healthcare reform affect the model and what's happening in the transitional care model?
So everybody heard the question. There are a number of initiatives that have come out that are in the final House bill, and we expect will be in the final Senate bill, that influence this approach to care. Many of them fall in the area of payment reform. There is no question that we're going to see incentives or disincentives to hospitals not to have 30-day readmissions. In fact, in both the House and Senate bill, there are provisions that say if you discharge a patient from your hospital and that patient is rehospitalized within 7 days, you'll have one sort of penalty, within 14 days and up to about 30 days. So there are incentives, all of a sudden, financial incentives, that will position and should be positioning hospitals, for example, to think about, well, what could I do? How could I reorganize myself to make sure, at least in the short term, that doesn't happen, that a high percentage of my patients are not readmitted within 30 days, and therefore I'm not penalized. So that's one example. There's also a movement, and again in both House and Senate bills, around bundled payments, which is to say that payments will be provided, and there will likely be demos of this, but the way that the language is in the House bill, and I think Senate will follow, is that payments will be provided to a hospital, but that really will force the hospital to very much act in partnership with people in post-acute care, in rehab settings, in home health, et cetera, to work together in order to make sure that this bundled payment, the bundled payment is for acute and post-acute care. And it will force them to work together to figure out how can we make sure that Mr. Jenkins, my accountability for Mr. Jenkins from hospital mission is now perceived to be including what happens in the post-acute environment. So that positions work such as ours, evidence-based transitional care, to be ready to come in to say, we've got a solution for you, because clearly we will position organizations that are interested in that partnership, because we've done it in our trials, and we're certainly doing it in our translational work. Then, finally, there are explicit provisions for transitional care services. So the Medicare Transitional Care bill that I talked about, that's been introduced by Representative Blumenauer in the House and Senator Shaheen and Collins in the Senate, has not made its way into either of the bills so far. So it's still out there into the major bills. But there are provisions for transitional care services. In the Senate bill, the provision is a $500 million investment over the next couple of years that will target hospitals with high readmission rates to use evidence-based transitional care services to address, to decrease those rates. Those transitional care dollars can also, dollars for those transitional care services can also be applied to hospitals that have a disproportionate share, meaning many of them, they're serving very vulnerable individuals individuals. If after a couple of years that investment shows a return, reductions in readmissions, there is a provision that would allow that to become part of the way that we deliver services. So we don't have to wait to go back to Congress and ask for permission. If you see the results, if Medicare sees the results as a result of these demos, then it can become essentially a benefit that will be available. The reason that there's not interest in our proposal is that we're seeking a benefit for transitional care services to be made available to Medicare beneficiaries. And without getting too technical, the Medicare Payment Commission and others believe that the disincentives of not paying for anything in 30-day readmissions will be enough. My view is that that's a limited viewpoint, because when you tell somebody to decrease readmissions for 30 days, guess what they do? They decrease readmissions for 30 days. But on day 31, they're all back in there. What we need is fundamental redesign to support the longer term impact. That's where you'll achieve both the quality, that's where you'll achieve the value. Improved quality, improved alignment with patients' needs and preferences, and decreased cost. You will not get it if you just say, keep them out for 30 days. We already know that. So, long answer, but those are some of them. Yes? It's over here.
How do you see your studies influencing nursing education?
Not enough. So someone said to me once, and I don't know if this, that it is, it's difficult to change curricula. I was an associate dean for a long time. I can attest to that. I think that sometimes it's easier to change practices. And we are seeing that. But there is no question that all programs need to be paying attention to a couple of things. One is population health, which we know, and the whole notion of prevention. And prevention, not just in a preventative primary care services, but prevention even in the work that we're doing. Because many of these people, we have great opportunity to delay progression of chronic illness. We have great opportunity to, delay one chronic condition from becoming 2 and 3 and 4. Huge opportunity. So we need to be positioning our graduates of the future to be able to think differently, I think. They need to be thinking about, how does my interaction with this patient and family caregiver today position them to have a long-term positive outcome. And I think that will happen. As the system changed, and the system's changing for a lot of right reasons and a lot of important imperatives. The imperative is Medicare 2017, no money. I mean, we will not have a Medicare system functioning unless we deal and address the cost issue in this country. So there will be much more attention to chronic illness. People on the Hill are talking about hospital readmissions. They're talking about chronic illness care, care coordination, transitional care. Our graduates and nursing graduates especially are in the prime position to be able to lead this movement. Bachelor's graduates are in an excellent position to be delivering the kinds of services, but master's graduates, and I do say masters, advanced practice nurses are in an exquisite position to be implementing these kinds of innovations, leading teams to deliver services that span settings, having panels of patients, high-risk patients, for which they're accountable. Some of the other issues in care delivery that what we're seeing on the Hill is a cry and a request for testing of community health teams that will be available to primary care practices, medical homes or health homes, whatever the language of the day is, that will enable nurses to be able to support primary care practices in the delivery of these services. So we clearly need to be thinking about how do we change the way we prepare nurses to think, to have a focus on community-based care, on prevention, on chronic illness care, to work in teams, to work longitudinally. I mean, those are some of the key lessons that we've learned from this work, and we've been working with this patient population for 20 years. So I think that, you know, we have to also prepare them to really understand quality. And what is quality, and how it is that you look at quality just in time, data just in time, and how it is that you can adjust the work that you're doing based on those data. So quality improvement is central in curriculum. I mean, preparing them to be able to do things like root cause analysis, et cetera. So you're probably already doing all this, but I think we need a movement in this country that positions us to really think about how we position our graduates to be able to be aligned with the changing needs. The reality is this: we're in this boat because of the terrific progress our country made in caring for acutely ill people. We prepared excellent nurses and others to deliver great acute care. And as a result, we have people living today who 10 years ago would never have survived their cancer, their heart disease. We have people in our program now who have HIV/AIDS as a chronic condition. People wouldn't have done that. And so we were exquisitely preparing graduates to deliver the right services for the right point in time. The population's needs have changed dramatically, and we need to be responsive to that. I think the other thing we need to do is keep everybody very healthy for as long as they can. Other comments or questions? Well, I especially want to pay tribute to the students for being here tonight. Anyway, thank you again.